Good evening, everyone. Namaskar, and a very, very warm welcome to yet another series of learning sessions presented by Association of Nurse Executive India's Patient Safety Fellows. This fellowship program started in 2022 in collaboration with Patient Safety Movement Foundation USA. And every year we have 7 to 8 fellows who had been doing this fellowship for 2 years. We have been bringing them to this webinar platform to share more learnings and more. Last year we focused on evidence-based practices, and this year it is not a particular domain. So we are giving our previous fellows of 23 to 25 opportunity to come and present. Alternate month, you will see a fellow presenting a quality improvement project. And in between, the 2024 fellows will be presenting on certain patient safety aspects. But before that, let me few things. And then while I am going to invite this month's presentation. Okay. So we are very, very proud to announce that the entire endeavor by Patient Safety Fellows, we have named it as SAFE, Safety Awareness for Excellence. So all that we are doing is to ensure that, we are paying more attention to our patient safety and safe practices. So these are monthly learning sessions which will be held third week or fourth week of every month at 7 p.m. So this already I told you brought to safety fellows, and we want to build a culture of safety and association with Patient Safety Movement Foundation. So that's the calendar for 2025. We are committed to doing all these sessions. And last year, yes, we were able to do all the sessions as promised. Maybe a little here, there, the schedule might have changed because of other reasons. So I'm very happy and honored to be, inviting Abdul Dhayan Razack. He's our ANEI Patient Safety Fellow of 23-25, and he is going to present his capstone project of the fellowship program, Scripted Nursing Communication for Better Outcomes. And before I ask to start, I will also be talking a little bit about the upcoming events as well. So in February, you'll be meeting Dr. Davinder Kaur, our ANI Patient Safety Fellow, 23-25. No, I'm sorry, it should be 24, 20. Yes, 24, 26. Speaking about making early warning score work. We highlight. And with that, I also wanted to invite all of you to Kochi Grand Hyatt. And for that, there are more people here, so let me do a very, very short video. Do come and join us on 30 and 31st of May at Grand Hyatt Kochi for our fifth annual conference, which is Anicon 2025. So hope to see you all in May in Kochi. And every time in Anicon, we do try to make it very multidisciplinary so that we live to our own promise of unsiloing nursing. because nursing cannot achieve anything without support and collaboration from every single department that we work with, and we are the largest department. So, in every Anicon, we try to ensure that we are reaching out to other departments. And this year, we are also initiating our alliance with young nurses, and we have called it as AYNA, AYNA, ANEI Young Nurses Alliance, wherein when we hold our Empower Hour every month, that's another initiative by ANEI, the state chapters are expected to bring in frontline staff nurses and nursing students into that, webinar in any format. So whatever that we do is to ensure and improve patient safety through empowerment of nurses. And all these learning sessions as we hold, we are hoping it will heighten the awareness of safe practices. So, without much delay, it gives me immense pleasure to invite Abdul Dhayan Razack. Please, you can put on your video. A very, very warm welcome, Abdul, and over to you. And it's 7:08. Please do take about 45 minutes, and then we will have Q&A, and then we will wrap it up. And I will also, in case you have any questions, feel free. We'll try to keep some 10-15 minutes. This is a project that has been done by Abdul as a capstone for the fellowship program. All the best. Over to you.
Thank you, ma'am. Thank you so much. So, namaste all and good evening, one and all. Thanks for joining. I'm sure that it's 7 o'clock in the evening and you're all getting back home. Thanks for showing that interest of joining to this particular, presentation. And first and foremost, I thank Tankam ma'am for having me onboarded as patient safety fellow, along with the other panel interviewers who were there. During my interview process. And thanks for having me onboarded and giving me this opportunity to present. So, with no further short delay, I'm just trying to pull my slide. Just give me a moment, please.
There are some black pants, Abdul.
Yes, ma'am. I'm just trying to close that.
It's now much better. You need to close that one. Yeah. Okay. Other one also. Yeah.
Yes.
When you're closing the other one, yeah, a little one has come up. Enter. I don't know what is that.
I
Yeah.
guess now it is better, ma'am.
I think it's okay. Let's not do anything. At least
Okay, great.
all
Sure.
sports are there here and there, but I think we can't do anything about it. Yeah. Go ahead.
Okay, right. Thank you, ma'am. So, starting with my presentation. So thanks. I'm just starting this presentation off or the safety awareness for excellence as a first batsman. I'm happy for that. Probably most of the time it happens in my name starting with Abdul, and I get lucky enough to have that particular first batsman opportunity. So no further delay, my topic or my QIP's discussion is going to be on scripted nursing communication for better outcomes. So this is about my presentation today. So this is my project team. Champion is Ms. Punita Singh, my reporting authority, AVP Nursing of Healthcare Global Enterprise Limited, and my mentor, who was a cohort one patient safety fellow, Ms. Shaini Verghese, and my team members are Ms. Sahaya, Mr. Daniel, Vasundhara, Jyoti, Rama, and all chemo nurses, consultants, and patients of the organization of HCG. So to go about this particular the topic, so we all know communication becomes a very important role in a nursing role or nursing day-to-day practice, and which has a lots of effect and impact on day-to-day nursing care activity. So taking this particular thing into consideration and keeping this in mind, so we took the communication on an important note, that we were just trying to understand what actually is all our process of communication, what our nurses are trying to do with our patient. right? So we all understand language barriers are there for nurses. Human emotions are there, like joy, fear, anger, anxiety, and sometimes very specifically talking about my hospital, we are the cancer care hospital. So most of the time, emotions come over, and the psychological upset or sometimes the stress, because we are seeing our own patients who have been cared for a longer time, they expire, and we're not able to give them a positive outcome. So in that particular cases, so there are lots of times when the nurses becomes more and more, um, upset, so the communication also get hindered there. So for to overcome all those particular things is what we tried doing was, we introduced a predefined script, or scripted communication as such, I could say, where which was kind of in scripts which is ready-madely available. A nurse has to learn it and try to adopt it. So what actually, how did we all start, or how did this particular thing go, is like, first we understood there were lots of negative complaints which are trying to come up very frequently by the consultants. And during our rounds, we started hearing lots of complaints or lots of feedback from the consultants saying that the nurses didn't communicate properly, this particular message was not passed to us properly, or this particular information was, kind of half. It was not communicated completely or something like that. And as well also from the patients, because as we all know, cancer patients require more about a follow-up, more about of instructions, more about of communications to be made, where the nurse become a liaising between a doctor and the patient attendants. Again, this particular complaint starts keeping on coming up, saying that the feedback was not given, this particular thing was not closed, we had asked for some doubts and it was not brought back by the nurse or something like that. And we also found during our hands off thing which was happening, where a nurse is trying to give and handing over, and that particular information was not passed to the next nurse, though we had some technique or defined a tool called ISBAR, but it's not happening properly. So we thought probably some sort of changes in the system would definitely help us create a better outcome. So that is the reason why this particular QIP was sought out, of thinking what could be done better on a communication. So we also did a root cause analysis to understand what basically was a problem. Why are we lacking? Though we had a very good training program, though we had a very good induction and all such things, but why did our nurse not able to do something more better? So when we broke out and kind of spread all these particular reasons, then we understood, taking the man as a part of one considerations, or the human forces to be as one of a thing, then we thought probably the nurses were not trained adequately on how to communicate, though we had an induction program device, but we didn't have something on communication. We were just trying to talk about a basic communication. We didn't specify about and something in detail. So that was one thing which we lacked. And next, we also thought about looking into the experience level of the nurses, where they were able to handle patients who are diagnosed with cancer, probably were they able to handle all those challenges what the patient is trying to put forth to them. So this was also one of the problem because of experience levels, and sometimes the attitude also was a problem. Apart from this, the familiarity of communicating with the patients, probably local language, usage of local language, or usage or avoidance of jargons, this were all also a problem. And take it for granted or casual approach, this was also an issue. And working on assumptions, like most of the time what happens with our organization is like, because these particular patients are more about a frequently visiting patients or regular patients, so nurses had this attitude of like, this has been explained to them because they have been continuously coming to us, they are in a follow-up with us. The association with the hospital, with the nursing team, is more about 6 months, 1 year. So working on assumption was also a problem. Along with this, we also looked into the other reasons, like method, what we are trying to approach and what was the methodology adopted. In that, there was a documentation issue and inconsistency in the handoff process. Probably just instead of giving a complete information or properly making it a proper tick mark, it was just kind of an haphazard here and there. And environment, again, as I already told you, stressful environment, nurse working in an oncology setup, we all know. And noise and distractions, sometimes where the nurses stations were too crowded, too noisy, this was also a problem. And coming from the management perspective or the administration perspective, we also had an inadequate staffing level, up and down here and there, attritions and all those things, and inadequate supervisions. Though we had layer of supervisors, but we also understood that this particular thing was not happening properly. So overall, to sum up, these were all the core issues what we had, and we thought probably it is high time for us to look into it. Otherwise, the feedback is going to be consistently bad. So with this particular thing, we created an objective of having a three focused, very clear objective. First was to understand or to assess the existing level of communication between patient and nurses, to understand, to have a raw data, right? For us to have a baseline to work on. That was our first objective. Second was to assess the level of satisfaction among patients and nurses on scripted versus non-scripted spontaneous communication. This was the second objective. And third was to evaluate the impact of scripted communication versus non-scripted spontaneous communication on specific health outcomes, especially in pain management, prevention of oral mucositis, and reporting of signs of extravasation. So these three were the main focus also we took up as an objective. So first is the current basic status, or for us to understand what exactly was happening. So we took this particular as a population size of 200 patients who were very specifically admitted in our chemotherapy department. And a structured questionnaire was given to them, and and it was again kind of an interview method and supported interview method too. And we understood it was all 50-50 percentage. So most of our time, our patients were not happy with the communication of our nurses, what they made. Probably if you look into the questions which has been spread out, we understood that they were not satisfied with the communication. The clarity was not good. Nurses were not empathetic, or the nurses was not trying to, address the concerns immediately or on the timely process, or the nurses were not approachable. That was also one of a problem. So most of the time, we understood that nurses became, too mechanical. Probably the communication became much about of a problem. So what we did was we tried developing this particular scripts. So with the help of PD, CA, we try to do a complete thing. So where in a planning phase, we all sat and thought like as a team, like what could be better done and how to create scripts. So we didn't have an idea of creating a script and how did it, to be flowing and all those things. So that was the time when we, thought of airlines. So probably this was again a tweaking or a copy from an airlines which has been used the airline industry since long, where our cabin crew try to have a script kind of created. So we adopted some ideas from there. Probably it was kind of in during a travel we tried. I personally tried recording the way they talk, all those things, and then it was kind of created. So what we did was we chose the main core areas like introduction and the how to communicate. Probably when we are trying to break up about the news of the plan of chemotherapy, about the side effects of chemotherapy, and regarding the health education or ongoing requirements, or probably sometimes the patients were also having the chemotherapy not taken because of the investigations. They had some issues with the investigation. So all those things were created in a form of scripts. And then what we tried to do is we tried identifying the SPOCs, or probably single point of contact, who will be the trainers kind of a thing, so that the next level nurses could be trained. So we identified team leaders, and not everyone were team leaders, maximum were team leaders. And we also identified some smart nurses, though they were junior, who were very smart enough to catch up, things faster. So what we did was we went on briefing and training them also. And after that, we looked into the readiness of them. Probably initially it was very difficult for us. I would say it was very, very challenging to make nurse accept the script and to make them memorize. So probably it was kind of Vivo was where the nurses behaved like a robot. Probably nurse educators and the team along with that, we all sat, we did a rehearsals, lots of rehearsals, and then probably we understood. Okay, now we are ready to go on with, and then we started going with an implementation. So that's the reason why we adopted a small unit so that much of the problem doesn't happen. So along with what we did was also we created our own videos of the scripts. Personally, I had recorded how to speak. These particular videos were all recorded along with my entire team of the champions. And what did we do was we tried to put it in our in the portal. We have something called in Spider, where which has been accessed by every nurse. So what we tried to do is we created these videos and we posted it there, so that whenever they had a free time, they started kind of rehearsing it. And basically, what we did was we created most of what our introduction introduction, self-introduction and proceed using an aided, and then ISBAR during an hands-off, and the exchange of information between doctors and the other healthcare providers, and the scripts basically very specifically care specific scripts like pre-chemotherapy counseling and pre-surgery counseling, conservative management, whatever is there. Then medication administration, very specifically about trying to talk about side effects and all those things. Discharge advice, transfer in and out here and there, right? So these were all the things which was created as a script. And we went on training. Lots of trainings was all there. And then we tried to go with small type of an, kind of an pre-preparatory phase where we as a team, we started acting as a patients, and the nurses started coming out and started communicating. So slowly we started introducing patients on an broken manner. Probably took samples of 10% on a daily basis, and then once that nurses were more confident, and the patients should also be kind of introduced with such different proceeds, because it becomes very kind of a recording or kind of a robotic thing for a patient also to see that nurses comes and recitate something and not with more about actions. So earlier there were lots of challenges for us to, we have to admit that there were lots of challenges where the patients were also not happy with that particular type of a communication, and slowly patients also started accepting it, and we started measuring this particular satisfaction among patients and the nurses on scripted communication. We saw whether the nurses were happy and the patients were also happy. To our surprise, we saw patients were also happy as well. The nurses were also happy. So again, a questionnaire was given for both. The same type of questionnaire was given for both the nurses and the patient to understand whether the happiness level or their satisfaction level was all okay. So we understood nurses' satisfaction level because it was kind of a set of nurses. It was not the entire population what we have covered. So they were kind of happy because they had lots of drills to undergo this particular practice. So overall, we found there was an happiness curve which was happening, and the patients were also happy. And few of the nurses were not happy here and there. We could see the spread of the graph also. We saw something around 5% here and there, and 30% here and there. So maybe also saw 20 to 30% here and there of dissatisfaction among patients and nurses. Again, we went back and trying to recreate and recorrect all those particular things also. And again, we started implementing the same thing because we were very sure that we are going to implement the scripts. Because we have taken this as a quality improvement project, and we want to do this on a successful outcome. So we thought, okay, let us not stop here, or let us not, go down with the, complaints or the feedbacks of the patients or the nurses when they were not happy. So what we try to do is again reinstigating it, retraining them, doing this, and it was kind of more about, kind of in practice, and more over practice. And finally, we understood, that nurses were all happy and the patients were all happy. But yeah, there were also, some patients and some nurses who were not happy. So again, we started measuring with the level of satisfaction among patients and nurses on spontaneous non-scripted. So because we thought, okay, when there is a half here and there, so why this particular issues are coming up here and there. So we understood here again, a few of the patients were happy, few of the nurses were not happy. So, but finally we understood, okay, fine, majority of the nurses and majority of patients are happy with it. And once the patient starts getting used with, because most of our patients are, follow-up patients, they keep coming to us once they are exposed to such type of scripts. So obviously they're going to, approve it or get adjusted to it. So with a full-fledged, we went on this particular thing in that particular department, and slowly we started also understanding to have an outcome. So we thought, okay, now we have understood, or we are just going with this particular scripted communications. So what is the outcome of it? Are we really looking only into the communication, or are we also looking into the outcome of such things? So in that way, we understood. We chose three basic important things, which is very common and which is very important for us in oncology sector. One was the pain, because we discharge patients with pain also, the complaints of pain. So there were lots of techniques which was taught to the patient using scripted communications. How do they approach, or what are the procedures they do it, and how do they do a home care pain management? How do they, kind of adopt morphine, usage at home? and how do they kind of self-administer morphine over the clock, over the symptom. So different categories of requirement on pain management was also addressed, and we slowly saw, and this particular patients were kind of called back. Okay, and we spoke to the patients over call to understand whether they were able to manage the pain on day 1, day 3, and day 7. And most of the time we saw slowly as the time was proceeding up. So the patients were able to manage much more better. One was because of scripts, and one was because of the follow-up what we also made. And again, the same script and the same type of language was used over the phone also to the patient. So you can see a widespread of patients where you are able to see that day 1, day 3, day 7, from the pain scale of 7, and then it slowly started moving to 4, and then it came to again 2, 1, 0 sometimes. So we were actually happy that okay, patients pain management was able to be successfully manageable. And we also had feedbacks from the consultants about asking like, did the patient call them regarding a pain, and our clinical nurse specialist and navigators. So most of the time we had a very good positive thing. So along with this, we also looked into two basic things. One is the oral mucositis, and one is the extravasation, because our oral mucositis incidences and the extravasation incidences were also more, where we had lots of patients coming back because the instructions given by the nurses were not readily understood, because the differentiation on the drugs, DNA binding and non-DNA binding was an issue here, and application of hot therapies or cold therapies again was an issue there. So we looked into this again. The same scripts, different scripts on home care education was also introduced here for the patients who were getting discharged, and the same protocol was used here. Day 1, day 3, and day 7. Again, a follow-up was done, and the same script again. If the day 1 of the if the patients were not able to kind of understand, or they had little bit of doubts here and there, the same methodology of the scripts was again used over phone to explain them how it has to be done and all those things. So we understood the oral mucositis ranges. So slowly started, the reporting of oral mucositis slowly started improving, so that we were able to give them a better approach, a better home care remedies, because every patient had a different reasons why they had oral mucositis. One, it was because of the chemotherapy. One was because of the infection. One was because of their nutrition imbalance and all those things. So what we tried doing is we tried tailor-made approaches here and there whenever there was an feedback coming up, whenever there's a complaint coming up, when there was an patients had an issue, or patient attendants had an issue of understanding those particular concepts. So we slowly started seeing that the rate of reporting started coming, and self-care started increasing up. And along with that, we also saw, about, looking into extravasation signs, because extravasation was one of our indicator also, and we were pretty bad in our extravasation, monitoring. And I could say definitely this particular QIP has not only improvised the communication pattern, it has also improvised the reporting and the early identification of extravasation, and making the patient understand the difference, as I already told you, DNA binding and non-DNA binding, and also making a nurse also understand the difference on this particular drug and what better has to be applied. Sometimes we also had reports that the patient had applied cold therapy and hot therapy for a longer time, and that also led to a problem. So lots of reports came up here and there, and then definitely we were able to kind of explain in a better way using the same classical form of a script. So we understood that the implementation of these particular scripts were actually really working on more better to us. So overall, as an end of a QIP, I would definitely say our sustainability is definitely a way forward for us. I wouldn't say we have successfully completed and we have taken up the entire organization as such, where a scripted communication could be implemented, or we have implemented. We are sure that we are still on a areas we have to implement for radiation oncology, a certain type of surgical oncology where patients come up with a follow-up and all those things. But as of now, our medical oncology department has sustained, and we are very sure that we have made this as a cultural integration. In cultural integration, we have definitely done as a part of a culture of the method where the nurse is trying to communicate the one. And the second is we have also made it as a part of a culture in introducing this particular scripted communication in induction, where our half a day on of our induction is having this particular communication methodology and the scripted communication, where the onboarded nurse are then and there being trained, and then and there being given these particular videos. Now we also started slowly moving into technology integrations, where all the nurses are being put into a WhatsApp group, where such videos are being shared with them, and so that whenever they have a time, they are able to kind of rehearse it, and also listen to it or hear it, and also observe it. So that was again one. And we have also slowly started moving into adopting different languages. Earlier it was only in English. Now we also have lots of patients who are on the schemes, right, from the local government schemes. So such patients are having difficulty in understanding the English as a language. So what we tried doing now is we have started slowly adopting Kannada language, because basically this particular thing was done in Karnataka. So Kannada is one of the medium, and we also started adopting Gujarati in the Gujarat region. So these are the two other sustainability forward what we have looked into. So where our patients slowly started, understanding this particular concept of scripted communication in their own language. So it is again more about of catchy for the patients than the English. So now most of our nurses are slowly started to adopt the local language scripts, so that the patients are having better outcomes of it. And empowerment has also been given whenever they feel communication is not properly given, or when a script is not being used properly in a right manner, or it was not even adopted by nurses. So we are also having a reporting cell now, so where the team leaders and any peer can definitely report saying that this particular nurse has not used a script as a technique of communicating, so that we are able to handle such nurses again, re-stress on the importance of this particular scripted communication technique, so that on a long run we are able to adopt the scripted communication as one of the technique of communication, and bring more about of discipline in communication between patient, nurses, between patient and the other relative others. Probably it can be also our consultants and the other people who are into it. So as a summary, I would definitely say it has enormously improved our customer satisfaction, that is our patients as such, because we had lots of negative feedbacks coming on the communication very specifically. So that was a only kind of reason which made us think and understand that communication or a script has to be created. So we have really achieved in that particular way. Our the trends of positive feedback on communication has really improved. So this is one success what we would try to portray here and be very proud of. And we are also looking into kind of sustaining this as a culture, as I already told you, because our organization is spread across India. So we are also looking into other regions also where we're trying to adopt it. And we are also looking into tailor making of different scripts on different aspects related to oncology. And we are also having an idea of putting it as an publicized platform somewhere, so that the other organizations can also be looked into. It's still on a pipeline, still on a verge of getting permissions and approval and all those things. So once that has all been done, obviously these scripts will be introduced, so that the other organizations and the hospitals can also adopt about scripts related to cancer. With this particular thing, I conclude, and these are the references what I have taken up to refer here and there during this particular preparation of script, to understand how the scripted communications otherwise also helped in creating a lots of better outcome and better successful impact on patient outcome. So I stop my presentation here, and thank you so much for your patient listening. I'm open for any discussion and doubts.
Thank you, Abdul, for that, very interesting and innovative method. Though in the literature, it may not be the very new one, but we know that communication is probably the most commonest reason for any patient dissatisfaction or even patient harm, including sentinel events. It's the third most frequently cited reason, root cause for sentinel events. So, very rightly said, communication probably is an answer for many different things, and we all know we do have challenge around communication. And I'm sure that you gave this airline, example is right. So I have a question that
Yes.
in airlines, what happens is when you do the scripted communication, after some time you also by heart that dialogue, and you are not even paying attention to that, that safety thing. Whatever comes up, we know after this they'll tell this, after this they'll tell this. So you don't pay attention. So how did you train to personalize this communication? Because if you just repeat what has been trained, the first step is obviously to train the script itself, and then how do you deliver? So what did you do to get this emotional part of it? They are also emotionally distraught, and you expect nurses to be empathetic. So how did you do that?
Yeah, thank you so much for the question, ma'am. So initially, as you are rightly pointing out, this was also a challenge where our nurses tried to convey the script what they have memorized. So it was more about a robotic thing. And again, we also had this particular feedback again coming as a negative where nurses not trying to speak properly. They come, they just vomit everything, and then they just go back, they vanish, and all those things. So again, what we try to do is the same thing as we have created champions. So rehearse, and our part of rehearsing became little more of scenario based. And what we did was we adopted this particular one unit of our daycare and chemotherapy department, and all these nurses had a special training and special time for rehearsing it. So what happened here was like the champions or the nurses themselves or the team leaders themselves, we pretended to be as patients and try to put across questions to them. Like, okay, if I'm not supposed to do this, like what should be done? So earlier it was like again a blunt answer given by the nurses and all those things. So slowly this modification of their tone, their voices, the answers like I'm sorry, I'm getting back to you, pardon me, can you just give me some time, I'm getting back to you. So though they didn't have an answer, but the polished way of giving an answer to them or stopping them in that particular thing helped us more. And then slowly the journey of inculcating this particular emotional aspect has come in. But to be very frank, or to be in reality, we haven't looked exactly into that emotional quotient of the nurses. How are they communicating? We haven't looked into it. But as a per se of bringing or introducing the scripted communication into our system, we are rigorously working into it. Definitely, we haven't assessed on how the emotion thing or that is getting affected here. So probably I will definitely look into this, ma'am. Probably in the future, I will try to continue the study also to understand what is the emotional part, what happens with the nurses here.
Okay, so thank you for that candid answer, because one of the things that come to my mind is, I'm sorry, when we were in Fortis, tried introduce scripted communication for admission, discharge, those key touch points, though we did not have oncology, because oncology is going to be more challenging because of the kind of diagnosis that they have. So, same problem we had. So, what we did was we found nurses who are great actors, and they are naturally good communicators. See what happened. We all are human beings, we all like to talk. But when we talk, we carry different emotions to different people. So when they come to hospital, they are not very comfortable talking to patients, and we are assigning them to them, but for them they are strangers. So they think I just have to give medicine and talk like a robot, and that's what it is. So we literally had to handhold them by showing, so there were two, three things. One is use technology. We did not have WhatsApp that time. Yes, you can record the same interactions with very good nurses who can put forth, when your nurses see, they should feel, oh wow, that kind of approach sounds very good, I like it, maybe I would like to be like that. And maybe you can look at, acknowledging or appreciating the most empathetic nurse. The script can only do so much, right? So, what happens when anything that happens in airline, which is like parrot, what happens? There is no story. But when
Got it.
someone changes that a little bit, bring some fun into it, that becomes a viral story because everybody listens. So for
Likes it.
you,
Yes.
you have a challenge, the patient is coming back to you, right? It might in a
Yes.
multi-speciality, maybe it will do the trick for the first episode, second episode, but for so I think your journey is going to continue.
Yes.
And no doubt, scripted communication will definitely negate a lot of things because that's a challenge among our nurses also. That what do you tell a person?
Right.
No? And even when you are giving medicine to a patient, you have to do education. But many times, they will just tell कि ये दवाई है आपकी, ये ब्लड प्रेशर के लिए अभी आपकी दवाई है, ले. What a wasted interaction. If they given that with a different tone, with a smile, and saying कि आपको ब्लड प्रेशर है तो अभी आपकी दवाई दवाई है, आपको कैसा लग रहा है? थोड़े दिन और आप दवाई लेंगे तो आपका बीपी भी कंट्रोल में आ जाएगा, है ना?
Right.
जानते हैं इस दवाई के बारे में, यू आर प्रिपेयरिंग एंड यू आर टॉकिंग इन अ वेरी नेचुरल मैनर. And I think these things don't happen overnight.
Very true.
It
Yes.
needs time. It needs time. So don't let go of the project
Sure, ma'am.
because your project is finished. So you will get into, multiple PDSA cycles in a
Right.
QMP. You have done maybe couple, or two, three cycles. It will continue to evolve and definitely create good quality, videos where you have nurses acting, those who are really, really can deliver those dialogues with the right tone and empathy. That might definitely you give it to them and say, keep on looking at this and try to emulate that, so that, and also tell them that you can turn around the words little bit. If you think that you have a better sentence, feel free to use that. But at least use this basic things. And I call them
Basically.
as magical sentences. The sentences that you put in that gives magic to that interaction should be there.
Yes.
So I think these thoughts were coming to me while you were
Sure,
presenting.
ma'am. Sure, ma'am.
There's one question here. What is using in your hospital for hot and cold therapy to prevent oral mucositis? Did you mention anything like that?
No, I was mentioning about hot and cold therapy for extravasation, was not for
Yeah,
oral
yeah.
mucositis.
Okay, got
So it was
confused.
DNA, non-DNA binding chemotherapeutic agents. We try to select cold and hot therapies.
Okay. Any of the participants, delegates sitting here, attendees sitting here, do you have anything to share, or do you have any?
Um, Ma'am, I am Major Beena from KIMS. Thank you, madam.
Yeah,
Good
hi.
evening.
Hi.
Yeah. So, a very nice topic, Abdul was telling. I also tried in my previous institution the scripted communication, the cardiology ward, actually. And it definitely brought good results and patient feedback and lesser complaints. So, adding to madam's that points, what I did was, so I gave the basic concepts. So, the points that you need to communicate, especially you're starting an IV, you're going for some procedure, giving medication. So, what are the things that you should communicate? Basic concepts. And I asked the staff itself to uh, script based on the concept so that they were able to put those concepts into their own sentences so that it was never looking like robotic communication because they should be able to stop in between if they ask something. So when there is an interruption in the script, they should not be fumbling down suddenly or they forget something like that. So that also they should be taught. The patient can ask something, they can interrupt in between. So if they are able to do all this, then it can look like a natural way of communication. So at the same time, in their own sentences, they were able to deliver the concepts. So that is one way I think that you can add some magic, as you said, or remove that robotic way of communication. Otherwise, it look to the patients, it will look like as if like they are vomiting out something and going. They may never listen as we don't listen the airlines communication. Most of the people who travel very frequent usually don't listen to them. It is like parrot, that is right. So here we have to add that emotional quotient while communication to the patient. So I tried that method. So I think that was so we didn't have that kind of a feedback from patient. They are not emotionally communicating. So this is something I think I feel they can
So I think
try.
thanks now for that inputs. So Abdul Razak, what I'm hearing is that you already have done the scripted communication.
Yes.
Now, level two is to give the concept that in this
Got it.
particular
Got it.
interaction, what are the common, narrative that needs to be there. And then you give your script as a sample
Yeah,
script.
Mhm.
Then you say, now you make your own script.
Got
yeah.
it.
So that they need not by heart it.
Got
It
it,
will
ma'am.
come naturally. Yeah, it will come naturally to them.
Okay, that's a great input.
Thank
Thanks
you.
for
Thank you
being
so
here.
much, ma'am. Beena, ma'am.
We have
Yeah.
Pinaki who is raised her hands. Yes, Pinaki.
Hi, good evening, ma'am. Very nice to see you back again. Always nice to see you and get your comment and valuable comment rather. And Mr. Abdul has presented so well. And I just wanted to have only one comment here is that it somehow it works. It's much better than not having script. Although yes, it is very important that we need to be very dynamic while we communicate and we can put our input if at all, because it should not be like a robotic behavior as you rightly said, ma'am. But what we have done here in Apollo, just to tell you that when we have now 15 communication script for various procedure. So what we did, we actually told nurses to create communication script, and we did the competition that who is going to come up with the best script, and followed by what we did, we selected finally, and we made them to have a role play, and then we are trying to record it so that it can be a learning material for all of us. So it was somehow, I'm not saying that 100% it helps, but more or less, now nurses are having something base at least to communicate and what we desire to have. So somehow this is a very complex subject, but it definitely works in certain extent. But taking this kind of project is really wonderful to hear. I'm so happy that somebody took up such a complex project and we can improve upon. And it's one of the IPSD goal as well. So thank you so much, ma'am. I think you are guiding and Abdul did fantastic job. Thank you.
Thank you, Pinaki. So that's another
Thank you so
idea,
much, ma'am.
Abdul, that
Role play.
have
Yes.
competition. That's
Com-
something that who comes, you give the concept and say, okay, let's have a scripting competition. So reward the people with the best script and run on and off. You already have the base material.
Got it.
You have also got the script. Now you do the same thing and say, okay, you got the script. Now we would like to hear your script. This is the concept, so we would like to run the competition. So that way you're engaging them. So usually in leadership, we always say, no, that when you want to get something done, make them the honor.
Yeah,
Correct.
yeah. Make use of them.
And we
So
give them something, they'll say,
Got
oh,
it.
they
Got
have
it.
no other work to sit there and think of all these drama things and give it to us. But you make them the honor. So you're the perfect way that you started, having a set of things that you can use, like Polo has got 15 scripts. That does not mean when a new nurse comes you give her 15 and say, okay,
yeah,
memorize it and repeat.
Memorize it. Yes.
So
Yes.
obviously you have to do activities in between to check, and as I told you, get the great actors among nurses and tell them we want to see the best empathetic, communication that you can give your video. You give them credits in the video. Who are the actors in the one, the empathetic nurse, Pinaki, patient, maybe somebody else, something like that means there is a lot of excitement. See, I always think nursing, we don't create fun. We think, nursing is a serious job,
Yeah.
but that does not mean that we have to be serious for everything. No, we do our job seriously, but how we reach there can also be through fun. That's what is simulation is all about, right? Role play is a form of simulation only. And sometimes there is something called a reversal role play. Reversal role play means you allow the person to be a patient and tell that you imagine that you have been diagnosed with CA breast. Now, verbalize what are the thought process. So sometimes the person themselves can verbalize, or someone who can think fast becomes the voice of this patient. So that person says, "Oh, I'm confused. I'm afraid. Am I going to die?" The immediate questions that can come to one's mind, you know. So you have this creative minds among nurses. Find them, use them. It is not everybody's cup of tea. So you need to find the talent. So you will have a pool of people who are ever ready to do drama with you. So I had a bunch of people in Fortis. Anytime I say, drama karna hai, madam bata do kya karna hai. I just have to give them the scenario. They will create the script. You say, ma'am, we'll call you after some time to see. I only have to go and see and give little input, and then they are ready to do the drama. They were my drama troupe. So create your drama troupe. Why not? Why not inside the hospital? Why only in universities that you will have dramatic department? Yes.
Madam, this also I tried in my hospital recently. This scenario based training and this scenario based training. So the educators were made the patient. So when the nurses, the new nurses, they were giving medicine, they were asking a lot of questions. No, I don't want that. I will not take medicine. So then they already got like stuck. What to do? So from there we could train them. So this is how patients may ask. So this is a very good way of teaching actually. This scenario based that came, I got it from you actually. Now I use it here. That is the
Great.
only way to train the new nurses. Otherwise, it is very difficult. They don't listen to what you say. They are lost somewhere else. So unless they are made to play, act, it will never stay back with them.
So great. We have a good number of people here. If there are no more questions, all are good, then I will, Davinder,
Just
you are unmuted. Yeah, go
yes,
ahead.
ma'am, I have only one thing that I want to like clarify. Like we have the different levels of patient. I think there should not be only one script. It should be sometime it should vary according to the patient level also. Because some patients they are from the different states, sometimes they don't, the level of understanding and level of baseline knowledge is different. So sometimes we should have instead of only one, it should have be depend upon the patient. So little modification we can do according to the patient knowledge level, I think.
Yeah, definitely. See, personalization, modification is definitely a given because we cannot tell
Individualized teaching, I think.
everyone, but
Yes.
it looks nice on GAN to say individualized patient education. Believe me, Davinder, it is a sentence in a book. I tell them, forget individual, just give me the basic communication, please. इतना
Okay.
तो बोल दो पेशेंट को, प्यार से बोल दो, बस इतना बोल दो, उससे ज्यादा करने की जरूरत नहीं है. It is actually a challenge to get even that.
Yes,
In
this is true,
principle,
ma'am. This is
all are.
really true.
Yeah, so I think what I think Davinder, what she's trying to tell is, if you have an elderly person with a diagnosis, if you have a young person with a
Yes.
diagnosis, how would you do? See, it is pretty kind of easy to write a admission script because you can include all the mandatory parts of an admission script and you can tell them, okay, now deliver. So as I told you, this is not an easy thing to do a project and close it. You'll be doing it for very, very, very long time. And
Long time.
after long,
Yes.
long time also, you'll say, we are still at it.
Still,
Don't
yes.
worry. This is going to be a permanent topic. If this was so easily solvable, the world will not say communication is the top 3 reasons for sentinel events. Forget about patient satisfaction, patient harm, sentinel event. Communication is the root cause. So I think all the suggestions, all the discussions are very, very important.
Yes.
And we have just started the journey. And I think anybody else, wants to contribute to the bank
Yes,
of
and
scripts, in any, maybe we can create a bank of, scripts, patient communication scripts. We can do that. We want more ANI members to be active and, contributing. You all are doing such great stuff in your own places. Why not pool the things and, try to do something more and then let people have it, because Annie is there for patient safety. Annie is there to improve nursing and nurses. So feel free, and thank you so much for joining, Abdul. Feel free to wrap it up, please, and we'll see you next month with Dr. Ravinder, Davinder, when we discuss early warning score, another very interesting topic, and a lot of people will definitely be joining, because that is part and parcel of every nursing department. Early warning score, how does it help and how does it fail? So we will discuss all that next week. And please do join us. And thank you for joining us. Over to you, Abdul.
yes, thank you, ma'am. So, thank you to all experts. Thank you so much. So, ma'am, first, before wrapping up, I would definitely say HCG will be very happy to contribute the script, to Annie on oncology, because we haven't, we are not multi-specialty organization. So, definitely
Okay.
oncology thing, we are ready to definitely share it. And apart from this, thank you so much for all the experts. My take-home message, I have four solid words. One is narrative, role play, competition, reversal role play. I'm taking this back home with all hope of implementing it again, and to have this continuous journey. And I'm sure that I'm happy. I was thinking probably in healthcare, scripted communication was never thought of. So we started initially, and I'm happy to see Pinaki madam, Veena madam have already, introduced it in a different aspect and different speciality. So um, I'm sure that I will be able to reach them back again if at all I'm stuck somewhere. And I'm sure that, ma'am, you are also there. Still, as already told, we haven't concluded, we haven't stopped anywhere here. So still, definitely, we'll be continuing doing it. So, this is my just an humble request also to all the others who are kind of listening to me or hearing to me, is slowly introduce this particular importance of communication to our nurses, because our novice nurses get lost when they enter the organizational hospital. There is something called reality shock, which they really have never experienced it. So small communication tips, small interaction. As I already told you, we missed introducing communication as one part of our induction module. And after all these feedbacks and bombardments, what we got from our management is what we understood and realized that we haven't given much importance for this communication. So my humble request and submission to all leaders who have connected here is, try to introduce this. As it can be in a half a day, or it can be a role play, or it can be a scripts, whatever we are trying to do, or kind of a videos what we can circulate. But please try to inculcate this as a part of induction, so that it definitely helps the novice nurses and also the experienced nurses. Sometimes experienced nurses take it for granted. As I already told you, we had this particular problem of मुझे सब कुछ आता है, मैं patient को जानती हूँ. So this particular attitude is also a thing. So thank you so much for your patient listening, and thanks for giving time, and thanks for all your valuable suggestions. And Tanka ma'am, thanks for guiding me always. And definitely, as all are saying, you're we are all fortunate to have you as a mentor. Thank you so much.
Thank you. And thank you for everyone for your, positive feedback here. Thank you, everyone. And see you next month. Till then, Shabak Khair and good night.
Good night, ma'am. Thank you so much. Thanks all.
Bye.